Hello, my name is Katie Thoren. First, I'd like to thank the organizers for inviting me to speak today. I am a clinical chemist at the University of Miami and oversee the routine clinical laboratory where we do testing for multiple myeloma, so SPEP-IFE testing, but also I'm working on evaluating and developing new diagnostic tests for multiple myeloma, specifically those that use mass spectrometry. So this is something that I've been working on for about 8 years. It's hard to believe it's gone by that fast. But today I'll be telling you about where we stand with these assays. So here are my disclosures. So today I'll be telling you why we need some of these new techniques. What is mass spec? So we'll go over the technical details of the different methods. Where are we? So how the techniques are being used currently and where are we going? So future applications, and just very briefly, some of the challenges that we might face in implementing some of these techniques. So just very briefly to kind of review, and this might be review for people, but I just want to get everybody on the same page. Laboratory tests that measure the monoclonal protein are really an important component in the diagnosis and monitoring of multiple myeloma. So I'm talking about the monoclonal immunoglobulin, or M protein, that's produced by the clonal plasma cells in most myeloma patients. And this has been used as a biomarker for a really long time. And traditionally, this is measured and followed in the lab using electrophoretic techniques, so serum protein electrophoresis and immunofixation. And these techniques have been around for a really long time. So I thought this was really interesting. This is a paper from 1939 where they recognized that the electrophoretic pattern of normal serum and serum from a multiple myeloma patient were different. It wasn't really until the 1970s or so where electrophoresis was routinely adopted in clinical labs for this purpose. And the technique that we use today is largely the same. There's obviously been some improvements in automation. But this technique, these electrophoresis techniques have worked well for detecting the M protein for a really long time. That's starting to change a little bit because the treatment for multiple myeloma has improved pretty significantly over the last 10 to 20 years. So what I'm showing here is the percent 5-year survival versus year and the drugs that were introduced. And now this data is quite old, but the overall survival has improved pretty substantially with a lot of these really effective therapies that have been introduced. So the targeted therapies, the monoclonal antibody drugs like daratumumab, and we also have, bispecific CAR Ts, combination therapies that have been really effective for the treatment of multiple myeloma. This has meant that patients are living much longer and achieving lower levels of disease and maintaining those lower levels of disease for much longer. So this means that we need tests that are more sensitive. So currently, the most sensitive testing that we have for multiple myeloma is bone marrow-based MRD testing. And this is a really important prognostic tool. And there's obviously a lot of data and a lot more trials to evaluate how we can use MRD for treatment decisions. And so MRD is an important component now for multiple myeloma. These tests are typically analyzing the bone marrow samples by flow cytometry or next generation sequencing and are very sensitive, but there are limitations to bone marrow sampling. So this is an invasive sample type. You can't sample frequently. The disease can be patchy in the marrow, so there's the risk of false negatives, and it doesn't account for extramedullary disease. We also need tests that are more specific. So many of the drugs, the targeted therapies here, are monoclonal immunoglobulins themselves. And so they interfere with SPEP and immunofixation. So here's an example of what this looks like on immunofixation. This is a patient with an IgG kappa M protein here, and this is daratumumab. So in this case, we can tell the difference between the drug and the patient's biomarker, but you can easily imagine cases where these run in the same spot and we can no longer tell whether the G-kappa band is really due to the patient's disease or drug. So that brings me to mass spectrometry. So mass spectrometry in general is a very sensitive and specific technique that's been used in clinical labs for some time now for other analytes. And maybe about 10 to 15 years ago now, people started looking at this for M protein detection. And the idea is that a monoclonal protein has a specific amino acid sequence that has a specific mass, and so we can measure that and track that using a mass spectrometer. So there have been several different methods that have been developed over the years, and I think if there's anything that you take away from this talk, I want you to realize that there are different methods out there with different sensitivities. There's really kind of three main methods, all of which involve breaking the immunoglobulin into smaller pieces. Intact immunoglobulin is actually really big and it doesn't ionize well in the mass spec, so it means we can't really get a good signal if we were to just look at that entire protein. So we have to first break it into smaller pieces. There's a couple methods that break the protein into separate heavy chains and light chains, and then we follow the signal from the intact light chain. So we can analyze this using MALDI-TOF mass spectrometry or liquid chromatography mass spec. And then the third approach actually breaks the protein into small peptides. And we are able to identify peptides that are unique to the M protein and track those very sensitively using liquid chromatography mass spec. So some pretty powerful mass spectrometers. So moving left to right, we have increasing sensitivity of these methods, but also increasing complexity. So I'll go into a little bit more detail about how these methods work. So I'll start off with MALDI because that's kind of been the most established method. So again, we're following the intact light chains, but we actually start with a purification step where we purify immunoglobulins from serum. And this is accomplished in 5 separate reactions where we're using reagents that are specific to IgG, A, M, kappa, lambda. And then we reduce disulfide bonds. So we just simply add a reducing agent that breaks apart the heavy chains from the light chains, and we analyze this mixture by MALDI-TOF. So what did the data look like? So if we consider normal serum and the IgG specific purification, we have separate IgG heavy chains, which are about 50,000 Dalton. And then we have the lambda and kappa light chains that were originally associated with the G heavy chains. And so if we scan sort of a wide mass range here, this is what the data look like. So when the proteins go into the mass spectrometer, they pick up charges. So they can pick up, anywhere from 1 to 4, 5-ish charges in MALDI. So they don't pick up a ton of charges in MALDI, but they can pick up multiple charges. And what gets plotted here on the x-axis is mass divided by charge. So the biggest signal here is really due to the light chains. So we have the light chains, the singly charged. Lambda is a little bit smaller than the kappa. And then we have the doubly charged light chain signal here. We can see the heavy chains here in multiple charges, but they don't ionize as well, meaning they're not producing a very big signal in the mass spectrometer because they're bigger and because they're glycosylated, so they just don't make as much of a signal. So for this method, because the doubly charged light chain kind of gives us the best signal here, this is what we focus on to determine the presence or absence of a monoclonal protein. So if we just zoom into this region of the spectrum, this is what it looks like. So again, we have 5 separate purifications. So this is the IgG purification, and this is the signal from lambda light chains and the kappa light chains. And this is normal serum. So we have, all the peaks here are broad, Gaussian, smooth. And so this is what normal looks like. Yeah. So this is what it looks like when you have the presence of a monoclonal protein. So here is an IgG kappa monoclonal protein. And what we get is very similar to serum protein electrophoresis, we are looking for a spike in the spectrum above your polyclonal background. So in this case, the monoclonal protein is quite concentrated. So there's, it's a very big spike, hard to see the polyclonal background here. But we are able to identify the presence of an M protein and determine its isotype. So because we have a spike in the G purification and the kappa purification, and these are at the same mass, we know that this is a G kappa. So again, this is signal from light chains. So what this is saying is we have a monoclonal light chain that was associated with G, and that light chain is a kappa. So this is a G kappa. So in addition to detecting the presence of a M protein, determining its isotype, we can also quantitate by MALDI. And again, this is similar to serum protein electrophoresis, where it's a relative quantitation. So in an SPEP, we do a relative quantitation where we integrate the M spike. That M spike is some proportion of the total area, and then we multiply that proportion versus total protein concentration to get the concentration of an M protein here. In MALDI, it's the same idea, except instead of looking at the total protein area here, we're looking at the total IgG area and multiplying it by the total IgG concentration. So this is specific to whatever isotype the M protein is. So if this were an IgA M protein, you would be multiplying this by total IgA concentration. So MALDI is great. The advantages of MALDI are that it's pretty high throughput. The mass spectrometer itself is pretty easy to use, low maintenance, relatively speaking. It's not as expensive as some of the other mass spectrometers that you can get, but the resolution is a little bit limited. And so if we want more sensitivity, we can look at other mass spectrometers. And here for the LCMS intact method, we can basically take the same sample prep that we analyzed by MALDI, and we can put it on a different mass spectrometer. So this is a generic term, liquid chromatography mass spectrometry, but really the mass spectrometer, you can use different mass spectrometers here that are more powerful, have higher resolution, and give us better sensitivity. So LCMS methods of the intact light chains provide better resolution and sensitivity compared to the MALDI. So here's what a sample would look like on MALDI. We can see, there's a polyclonal background here, and you see spikes above the background. And this is what that sample looks like on LCMS. So much better resolution. So the peaks are very, very narrow and much more separated. We still have a little bit of polyclonal background, but some of that gets cleaned up because of the liquid chromatography step prior to the sample going onto the mass spectrometer. So this method ends up being about 10-fold more sensitive than the MALDI. And finally, looking at the most sensitive method, but also the most complex method, we have the clonotypic peptide approach. And the complexity of this method really kind of is related to this first step here, where we have to identify peptides that are unique to the M protein. So this step is done once per patient, and most often this is being done by de novo sequencing by mass spectrometry, or using mass spectrometry to determine the amino acid sequence of the monoclonal protein. And you really have to do this when the M protein is concentrated enough in that serum sample. So the steps involved here are you have serum, you add enzymes to digest the proteins into peptides. The peptides get analyzed by mass spectrometry. Bioinformatics is used to sort of align all those resulting peptides and figure out which ones belong to the monoclonal protein and essentially stitch them together to reconstruct the amino acid sequence of the monoclonal protein. And finally, certain criteria are applied in order to select peptides and make sure that they're unique to the monoclonal protein and that they're going to behave well for mass spec analysis. So once peptides are identified, in all follow-up samples, you're going to detect and quantitate those peptides using targeted mass spectrometry. So what I mean here is in targeted mass spectrometry, you tell the mass spec to only look for those specific masses, and it's not going to look for anything else. So this is part of the reason why these methods are so sensitive, because you're only looking for those specific masses, and you don't get interference from polyclonal background or therapeutic monoclonal antibodies. So this method ends up being about 1,000 times more sensitive than immunofixation. So in terms of advantages and disadvantages, first for the intact light chain approaches, advantages is that these tend to be simpler methods with minimal sample preparation. Importantly, this is a universal workflow, meaning that all samples are treated the same way. And because data are collected in an untargeted way, meaning you're not telling the mass spectrometer what to look for, you just collect everything. You technically don't require prior knowledge of the M protein mass, but I put an asterisk here because it is really helpful to have that knowledge ahead of time, so you know kind of what mass you're looking for, and you know that belongs to the original clone for that patient's disease. These methods also, because they're simpler, they tend to, relatively speaking, be faster analysis compared to the clonotypic approach. The disadvantage is that we are limited in terms of sensitivity because we have that polyclonal background. So again, it's similar to SPEP where we have to see a spike above the polyclonal background. So the clonotypic peptide has an advantage in that it is the most sensitive approach, but it comes at a cost that the methods tend to be a little bit more complex, especially this peptide identification de novo sequencing part of the method, which requires pretty significant expertise, bioinformatics, and also pretty powerful mass spectrometers to be able to do that de novo sequencing and identify those peptides. Another disadvantage is that this is a patient-specific workflow, meaning once we've identified those peptides unique to the patient, when we tell the mass spectrometer what to look for, that's going to be different for every patient. And finally, not all M proteins produce unique peptides that are amenable to mass spectrometry analysis. So now that you know how the methods work and their disadvantages, advantages, where are we? So what are the current applications? So what we know, and we have a pretty good understanding about the analytical performance of these methods. We know that they have better analytical sensitivity than immunofixation, and these are kind of rough estimates about where they fall in terms of their sensitivity relative to IFE. We also know that they have better analytical specificity, right? So following sort of the exact mass of a protein is sort of much more specific than paying attention to its migration on a gel or capillary electrophoresis. And finally, at least for the intact light chain approaches, they provide unique information, particularly about glycosylated light chain. So I'll talk very briefly about this in a little bit. But what does this mean? So what do these analytical advantages mean in terms of clinical utility? So to kind of, I think a good summary of where we are currently is given in this IMWG working group publication. Now, this was a publication back in 2021, but this is largely still, holds for where we are today. So first, the IMWG endorsed the use of MALDI as a replacement for immunofixation for clinical assessment of patients and for clinical trials, with the caveat that CR rates may be affected due to the slightly better sensitivity of MALDI compared to IFE. So they caution that the techniques really shouldn't be used interchangeably, and you should stick with one, especially for trials, you should stick with one in determining CR rates. So currently, this is being used clinically. There's a major reference lab in the United States that's using MALDI as a replacement for IFE. And sort of an update to the IMWG guidelines. More recently, they're also using it as a replacement for SPEPs. They're using MALDI quantitatively. I'll also say too that the binding site is commercializing this method as the Exent system. It is CE marked, but it's still under review at the in the US, so it's still under review at the FDA, hence the disclaimer at the bottom. Number two, the IMWG endorsed the use of mass spec as an aid. So they said it's useful for distinguishing monoclonal proteins from therapeutic monoclonal antibodies. So again, here's an example of this. You've already seen this figure, but here's an example of a patient who has an IgG kappa M protein who is also taking daratumumab, which is an IgG kappa monoclonal antibody drug. And here, using MALDI, we can tell the difference between the two peaks. MALDI works very well for this, but it's not perfect because the resolution of MALDI is, not perfect. And so there have been a couple studies that have found that when looking at IgG kappa M proteins, being able to distinguish them from therapeutic drugs, MALDI works in about 85% of cases. But with the improved resolution and sensitivity, LC mass spec analysis of intact light chains works 100% of the time. So because of the much, much better resolution, we can separate M proteins and drugs better using this technique. Number three, the IMWG said that more data is needed to understand the clinical utility of glycosylated light chains. So here's what a glycosylated light chain looks like on MALDI. We see sort of this higher mass blob of peaks. So we get these multi-peak signals that are higher than the mass range that we typically see for the light chains. And so this represents the different glycoforms of the protein. And this has been actually a really cool finding because this is something that you can't see with electrophoretic techniques. But when we started looking at the M proteins by mass spectrometry, we can get some structural information shown here. So what's been interesting is that there's been several studies that have shown about 3 to 5% of patients have glycosylated light chains. And they are observed more frequently in patients with amyloidosis. They might be a risk factor for progression, but kind of more work is needed to really understand their clinical utility. But this has been an interesting finding, at least with the intact light chain methods. And finally, IMWG suggests that more data is needed to understand the use of mass spec in the setting of MRD. So I think this is probably to me, the most exciting application of mass spectrometry for multiple myeloma, because this has the potential to serve as a blood-based MRD test. So blood-based tests are really attractive because obviously they're less invasive than bone marrow. They have the potential to detect extramedullary disease, probably will be less expensive than bone marrow sampling. But I think Most excitingly, because they're less invasive, we can sample more frequently and kind of follow the patient more closely here. And kind of an example of what that looks like is shown in this publication here, where mass spec is really showing the kinetics of the M protein. So in this study, they were analyzing serial samples from patients from the IFM 2009 study, and where they had many time points per patient. And the mass spec data is shown in blue, and I should say this is the clonotypic method, so the very sensitive method. And the SPEP data is shown in orange, and the open triangles mean that the SPEP was negative. So obviously, we're much more sensitive than SPEP, and we can track the protein at these low levels and see what it's doing. So there are examples of the monoclonal protein kind of being stable. Continuing to decrease in concentration and going negative even by the mass spectrometry method, or increasing in concentration, showing a relapse. And so I think this is really exciting. It might kind of change how we're doing MRD because we can look at kinetics or sort of dynamics of the M protein. Also in this study, they found that they can detect an increase in M protein concentration earlier than conventional techniques, and in some cases, much, much earlier compared to SPEP. So here for this patient example, progression was, as defined by the trial, was noted at this time point, but mass spec was detecting an increase in M protein concentration much earlier. And also to note, these points here are bone marrow results. So the MRD was positive at this point, but the MRD was negative here. And interestingly, just before they saw an increase in protein concentration. So, obviously we still have a lot of work to do to understand the clinical utility of mass spec in the setting of MRD. And some of the questions that we and others are trying to answer are whether mass spec can be used in conjunction with bone marrow-based MRD or perhaps as a replacement. Can it be used, so if used in conjunction, can it be used to appropriately time and therefore maybe minimize how often we're doing bone marrow testing? And what is the appropriate setting? So could this be used to detect early relapse? There's some trials now that are incorporating mass spec that are looking at treatment or maintenance cessation. So I think that could be a really interesting application of mass spec. So definitely still a lot of work to do here. There have already been several studies looking at this, and kind of we're looking at all of the techniques as a potential blood-based MRD approach. And so all of the techniques have been compared to bone marrow-based MRD results. And in general, results are concordant in 60 to 80% of the samples. It's a little bit hard to directly compare the mass spec results to bone marrow because it's like comparing apples to oranges, measuring protein versus cells. And so when you have discrepant results, it's hard to know which ones is correct because there are limitations to both of these tests. So really what needs to be done and what is currently happening is that studies, like clinical trials, looking at comparing the mass spec results to patient outcome, and then also comparing that to how bone marrow predicts patient outcome. And so one of my favorite studies is this one here done by Ben Derman and colleagues at the University of Chicago, where they compared MALDI and LCMS of the intact light chain method to NGS bone marrow MRD. And they found that LCMS status was a better predictor of progression-free survival compared to NGS or MALDI. So if you look at these two plots at the bottom, so we had none of the patients who were LCMS negative at cycle 18 experienced progression or death. And of the patients who were NGS negative, a portion of the patients who were LCMS positive experienced progression. So this is certainly the type of studies that need to be done in order to really figure out the clinical utility of these methods compared to bone marrow and figure out which are better predictors of patient response and patient outcomes. So there are some challenges to the adoption of mass spec techniques. In terms of replacing SPEP-IFE, I think some of the challenges really have to do with practical considerations of the lab. So things like cost and reimbursement for the lab, making sure that the methods are, in fact, more efficient, higher throughput for the lab compared to the electrophoretic techniques. Certainly, some of the gel-based methods are labor-intensive, but there are sort of more automated ways, capillary electrophoresis, for example, that are higher throughput than manual gels. So making sure that we're comparing the mass spec methods to sort of the automated versions of electrophoresis testing. And also some things to consider, sort of, before this is more widely adopted by clinical laboratories is, can these methods be standardized, and are they making sure they're easy to use for clinical labs? And obviously for blood-based MRD testing, some of the challenges, obviously, we need to establish the clinical utility and figure out their appropriate setting, how to incorporate these tests in with, possibly alongside of bone marrow-based testing, and when to use them also even relative to SPEP-IFE or, some of the methods that measure higher concentrations of the M protein. Another thing that I didn't talk about very much, but the long half-life of some of the M proteins is a confounding factor. But I think when we analyze how the tests predict patient outcome, progression-free survival, I think this will kind of come out, and we can also maybe look at rate of M protein change if just the presence or absence of an M protein is not a good predictor. So with that, to summarize my talk, the treatment for multiple myeloma has improved significantly, which is driving the need for more sensitive and specific blood tests. So there are several mass spectrometry methods that have been developed to measure the M protein. MALDI is currently being used as a replacement for SPEP-IFE in at least one lab in the United States, and probably down the road, this will be more widely adopted as it becomes commercially available. The improved specificity is useful for distinguishing therapeutic antibodies from endogenous M proteins and can help identify the patient's original clone. And the use of mass spec in the setting of MRD is promising and I think probably very exciting, but we're still understanding the clinical utility of it. So I'd like to thank you for your attention and thank my colleagues, especially Dr. Langren and colleagues at the Myeloma Institute at the University of Miami. So thank you.
Thank you very much, Dr. Thoren, for really a beautiful, wonderful talk, I must confess, because you've made it very easy for us, very visual, to understand what people usually consider as a complex field. So we have a lot of questions, so I'll try to structure them. So first of all, the question is about MGUS. And today, the incidence of MGUS increases with age, and now with more sensitive technique like mass spec, more and more patients will be diagnosed with MGUS. And the question we have, is this something which is desirable? I don't know whether we know the answer, but what are your thoughts on this?
Yeah, so that's a really good question. And there's been, several studies that have looked at this and definitely shown, increased incidence of the presence of a monoclonal protein when you use these more sensitive techniques. And so I think it's, some of the studies have even found, say, 10 to 20% of people have a small, low-level monoclonal protein present and at very low concentration. So I think it's challenging. We still don't really know how to use the more sensitive techniques in that setting, because we don't know if those really low concentration monoclonal proteins are clinically relevant. Um, I think some of the studies have shown that they tend to be transient, so detected uh, sometimes, but then when tested again, they go away. But it's certainly an area of a lot of work, and still don't really know how to use those in sort of an upfront setting, because you just don't have the specificity to know whether that M protein is going to be clinically relevant or not.
Thank you. Another question is, outside hematologic malignancies and especially multiple myeloma, are there other diseases and fields in medicine where this kind of the use of mass spec would be useful and necessary?
Yeah, I mean, in general, mass spec has been used in the clinical lab for other analytes. It's typically been used for small molecules. So, uh, drugs of abuse, it offers very sensitive and specific identification of drugs, of hormones. In terms of
Almost a
use.
quality control. Sometimes I hear, if you have doubt about whatever drug or
Right. Yeah. So typically, we use, so if you look at drugs of abuse, for example, we'll do sort of a screening method uh, for initial, presumptive positive, but then that gets confirmed by mass spectrometry, because mass spectrometry is going to be more specific. So yeah, that's those. There have been several mass spectrometry methods used already in the clinical lab for many years. When you talk about mass spectrometry applications to measure proteins, those are kind of more new to the clinical lab. So there's some examples where, specific proteins have been measured, thyroglobulin, for example. And again, mass spec provides better specificity. What's really unique about M protein detection is that the M protein is different for every patient, right? So it's not measuring, you're not developing really one assay for like thyroglobulin, which is going to be the same in all people. So, especially when you talk about the clonotypic peptide approach, the analyte that we're measuring, because we're identifying those unique peptides, it's going to be different for every patient. So, from a lab perspective, that's challenging. And kind of a unique sort of lab uh, thing to think about. So,
Okay,
yeah.
thank you very much. We have a provocative question about Malditov, for instance, replacing immunofixation and electrophoresis. And the question is this really necessary?
So that's a good question.
Besides the cost. And that is
Besides the cost. So, is it clinically necessary?
yes.
So, it's a good question. So, I think, you know, we're still, and the part of this research that I really enjoy is trying to figure out how to best use these techniques, how they best fit in with each other, and how they best fit in with our current techniques. And so that's a really good question. I think there's going to be, right? So, like, maybe we don't need that sensitivity upfront when patients are first diagnosed and they have high levels of disease. Um, so I think probably mass spec is going to be most impactful for, you know, being able to detect really low levels of that monoclonal protein. I think, though, there is potentially still, an practical benefit, right? So if we're not talking about clinical benefits up front at high levels of disease, there's still a practical potential benefits to the laboratory. Um, Ultimately, maybe improved efficiency, perhaps improved cost. These things are still kind of in the works. because SPEP and IFE are pretty well established techniques. They still work really well for those high level of disease situations. And so I think where you're going to see replacement of MALDI, or sorry, MALDI replacing SPEP IFE is going to be for practical reasons for the clinical lab.
Excellent. So that brings me to the hottest question we have in the myeloma field, which is about using mass spec and the most sensitive, method to replace MRD, because we're struggling with these bone marrow aspirates to be repeated. I think the patient never liked them,
Yeah.
and we don't like to do them. And how close or how far are we from switching to, because it looks like to me that one of the mass spec methods, so I don't know who's the manufacturer, maybe Sebia, is highly sensitive. And it's almost, I guess it's almost ready for prime time. What can you say about this?
Yeah, so you're talking about the clonotypic approach. So there's actually a couple companies, one in the US, one in Canada, that are offering laboratory developed tests using that clonotypic approach. And of course, they're going to vary slightly in terms of their sensitivity and the exact details of their method. But um, so yeah, so those are currently available. Like we're still trying to figure out how to interpret those and how to use those results, what it means to have an M protein at those low levels. And in terms of how far away we are in and whether they are going to completely replace bone marrow, I would say I don't think they're going to completely replace bone marrow testing. Uh, I think they have the potential to significantly reduce how often bone marrows are being done, and in terms of appropriately timing when a bone marrow biopsy is needed. But because you're measuring cells versus the product of the cells, I don't think you get different information from bone marrow testing, and I think probably it's going to be really important sort of later in the patient's uh, disease trajectory, right? So like, of course, you need probably still a bone marrow at diagnosis and sort of establishing. So I think it's going to take a while to compare the techniques and to have enough data to show that mass spec can be used, or even some of these other blood-based MRD testing can be used sort of as a replacement or sort of a way to reduce the amount of bone marrow testing needed. So, though these techniques are being incorporated into a lot of clinical trials, but it usually takes several years to have enough data to say that. So.
But because we have a lot of patients and families watching, I think we can give them an optimistic message that it's coming at some point.
Yeah, so I mean, so I would say it's something to think about now. It's something that, some of the techniques are available, right? So, there are companies that have validated their assays as laboratory developed tests and are offering them. And so it is important to start thinking about this now because, you know, it makes it a lot easier when the M protein is detectable that you get the mass of that M protein on any of the techniques, right? So if either by MALDI or especially for the clonotypic, to be able to have that M protein is concentrated enough that they can do the sequencing and identify the clonotypic peptides, right? That has to be done when the M protein is detectable. So it's a little bit challenging, because especially when you're thinking about these tests for MRD, you really need to be thinking about them up front to type and get the mass of the M protein early so that when they are at low levels of disease or in sort of MRD state, that you can do the test and be able to say for sure that the M protein is present or absent. So I would say that's something that they think about early and do this testing early.
Okay, we'll take one last question, and this is about whether you can comment on the role of mass spec in those patients who are suspected of having extramedullary disease in myeloma.
Yeah, so I think this is also going to be an important application. That's a really good question, because of the possibility of, detecting circulating biomarkers, detecting the circulating M protein from extramedullary disease, something that you may miss when you're doing a bone marrow biopsy. So I think this could be an important role for mass spec. Yeah.
Wonderful. I think we've reached the end of this ICH webinar on mass spec and multiple myeloma. I think Dr. Thoren very strongly highlighted and convinced us, at least convinced me, about the transformative potential of this technology in improving disease monitoring and response assessment. Uh, the superior sensitivity is here compared to traditional methods. The utility in detecting MRD and the role in refining patient stratification definitely are improving, and I believe the field will continue to move forward towards more precise, more personalized treatment approaches, and mass spec stands out as a promising tool to guide these clinical decisions and enhance, at the end of the day, outcomes for patients with multiple myeloma. Thank you, Dr. Thoren, for sharing your passion, your knowledge, and for being really making things very simple to us in the clinic. Thank you all for being loyal to the ICH activities. And as usual, wherever you are, please stay safe and keep well. This is the International Academy for Clinical Hematology around the globe and across the hematology field. Take care.